Welcome to the Oakland County Medical Control Authority Protocol Update. We have 10 protocols that we have made either minor or major changes to that we're going to briefly go over in the next few minutes with you. I am Bonnie Kincaid. I'm the Executive Director of the Oakland County Medical Control Authority, and
I'm John Twite, the Director of EMS Operations for the Oakland County Medical Control Authority. So like Bonnie said, we got 10 protocols. This is the list right here. Some of them are really, really easy changes, and one of them is pretty substantially changed. So we'll start off with 4.5 pediatric respiratory distress. On line 5, we added racemic epinephrine. It appeared to be left off inadvertently, so it was just re-added. It doesn't really change how you're going to care for the patient. It should have been there in the first place. The next one was CPAP, 7.5. The confusing language regarding when you could discontinue a CPAP was fixed. The goal was to better clarify when it was appropriate to discontinue a CPAP.
the really exciting protocol that was pretty drastically changed is 7.13 pain management. And we did a study, and then we found other literature on how to dose fentanyl for pain. Instead of finding the exact weight and trying to draw up, say, 66.5 mics, now you'll just either round it up to 75 or round it down to 50.
And that's a huge change. That's what we do in the field. We weren't necessarily going by the patient's weight. We were guessing the patient's weight to begin with. And then if they gave us an exact weight, then we were doing our best to dose that way. But what we found in the study was out of 698 administrations, only 69 administrations were not 25, 50, 75, or 100. When this was presented to the physicians at the OCMCA, the physicians said, yeah, that's what we do as well. We don't give the exact dosing. That was also presented to the state. We found some studies that showed that giving a little bit more fentanyl is not dangerous to the patient. The state of Michigan reviewed it and they said, this actually makes sense. So it was changed. So the way we give fentanyl now is changed going forward. And we can give 25, 50, 75, or 100 based on the patient's weight, rounding to the nearest one. There was one thing in there about patients above the age of 65. This was a change from the previous protocol, and this is just something we wanted to point out to all of you. The dose for above the age of 65 is cut in half. It is 0.5 micrograms per kilogram. One of the other changes we did was on line 12, there was some language about ketamine and different situations. We simplified that language. It just says, if ketamine was not administered and the patient has significant pain, you can go ahead and give analgesia. There was some confusion in the way it was worded that people thought, well, maybe I got to call med control if I want to give morphine or fentanyl. No, if you're going straight to the morphine or fentanyl, you do not have to contact medical control first. The next protocol was 7.16 patient restraint. This was a typo. It was a clerical error. Pediatric patients ... was in the indications. We took that out of indications because it didn't belong there, and we simply moved it to a note. The next interesting protocol was 7.23 vascular access and IV fluid therapy. All the changes for this one are on page 1. We added a note to remind providers that they cannot use pre-existing lines like PICC lines, central lines, fistulas. Some of these are put in through surgery. And if we utilize those lines and something goes wrong, now that patient, which is getting life-saving medications, dialysis, things like that, has to wait to have a surgery before they can get dialysis or their life-saving medications through the hospital. So we need to make sure we're not utilizing those ports. The other interesting thing about this was the IO indications. The indications for IO are adult and pediatric life-threatening situations where venous access using peripheral veins has been unsuccessful. In the old protocol, then there was a list of indications where it said cardiac arrest, severe burn, shock, severe multi-system trauma. And then there was a confusing statement at the bottom that said, if it's not one of these, contact medical control. The confusing part about that was you had an indication in the top, then you had these situations that you can do it, but then if it wasn't in those situations, you had to contact medical control. So you kind of had conflicting indication. So we simplified it. We removed contact medical control and just made that list a non-exhaustive list that said it may include the following: cardiac arrest, etc.
The next one is 7.28 LVAD. It had blank contact information, and so we took that out and said, if the information is not readily available, contact medical control for assistance. This is big for LVAD patients. You don't want to fool around with them. You want to contact medical control, tell them what you have. They'll direct you to go to the appropriate facility.
The physician that you contact when you contact medical control is going to help you determine what facility that is. I understand it says in 2F, prepare for transport to an MCA approved LVAD hospital. There is no LVAD hospital in Oakland County. However, if the physician that you contact says, you need to transport this patient to Henry Ford, Maine, or U of M, you may need to be ready to transport them to the closest appropriate facility. Now, if that physician says, bring that patient here, we can handle that, then the closest appropriate facility is the one that's saying, bring the patient here. So we wanted to make sure that you understood those two lines in there as well.
The next few are pretty simple. 8.8 Air Ambulance Personnel Scope of Practice. This is a new protocol that really is for the aircraft transportation agencies. But one thing to review is 8.9 Aircraft Transportation. There's a lot of changes in that protocol, so if you do call in helicopters on occasion, please read through and make sure you're aware of all those changes in that protocol. 8.15 Interfacility Patient Transfers. That's a pretty easy one. We just removed a reference to the protocol that we did not accept from the state. And then last on this list, 10.6.1, the MCI, OCMCA Initial Patient Hospital Transport. This addendum was added so that you know if you have an MCI of huge proportions that you're going to just utilize what we always did before. 2 patients go to a hospital, then the next hospital gets 2 patients, then the next closest gets 2 patients, and so on, so that we're not overwhelming any particular hospital. This was not incorporated into our February 1st protocol suite, so we just brought it back in, so it's there for you to know how to handle an MCI with your patients.
And that's really just about it for the protocol updates, but we did have one more that we wanted to talk to you about. Since the implementation of the previous protocol suite on February 1st, there was some discovery of some protocols that may be not as understood as others. One of them in particular is 4.8, Safe Transportation of Children. The state of Michigan has indicated in this protocol that they really want you using the ACR. Now, there's all kinds of acronyms in here. There's ACR and there's CRS. CRS is a child restraint system. That would include car seats, things of that nature. However, the ACR, the ambulance child restraints, is a subset of the CRS, and it's a specific type of restraint used for ambulances. The state of Michigan wants you to use the ACR. If you don't, then you must report it to the MCA. And the MCA has to look at every one of these incidents. The most important thing is that you document very well as to why. Document why you decided not to use the ambulance child restraint system. The other thing to keep in mind is that this should be the exception rather than the rule. You should be using the ACR as the protocol suggests. And that's all we got for you today. We want to thank you guys for all that you do. We know that the protocol suite, there was a lot of changes and you guys had to absorb a lot. We've made some fixes to some to make them make a little bit more sense. We just thank you for your patience and thank you for following the protocols.
Thank you. Have a great day.